Hello, welcome everyone, and thank you for attending this Fundamentals of Research course, which is being designed particularly for residents and fellows to help them undertake their research at KKESH. So when you undertake your research, you'll encounter a research question, and that research question might be a result of a clinical observation that you have, or as a follow-on from a previous study. And as a result of that research question, you'll arrive at a conclusion. Along the way, there are various study methodologies that you can employ, and there are various processes at KKESH that you'll need to undertake, including research planning and IRB submission. So the aim of this course is to have an understanding of the different types of study design in developing a research protocol, to know the research processes of the IRB and research department at KKESH, and to highlight the important points about writing a manuscript and having it accepted for publication, ideally in a high-impact journal. So we have a whole program of talks for you today, and we'll have 2 breaks in the middle. So I'd like to invite Dr. Deepak Edward to give the first talk on resources at KKESH and Research Centre to perform research.
Thank you, Dr. Rizwan, for that introduction. And I think one of the things I'll say up front that I think we're very fortunate here at KKESH to have the resources we have at the Research Center to perform research. I'll just say that up front. Having said that, we'll kind of run through the journey of research, or at least the flow of how research happens at KKESH. As Dr. Malik pointed out, you identify the research question, and that can be with a mentor or without a mentor, typically with a mentor. And you'll hear this thing about the research question over and over again in this talk. And it's a really important thing. So how can the research center be a resource for that? You have a lot of people between Dr. Malik and I, the biostatistics team, the epidemiology team, the molecular genetics team, who can all help you correctly formulate the research question, and also maybe identify a mentor if you're shy or you don't know people in your department. That resource is also available. Once you get that research question in mind, the next, of course, is to conduct a literature search and in parallel formulate a hypothesis based on that research question. So like I said before, mentors, ideas, refining the core ideas, and that will help you define the paper itself. Now, literature review sometimes can be challenging, and I'm sure all of you have done this at some point in time in medical school or as a resident here or elsewhere when you train. And PubMed is the source usually people go to, and at that point you have sometimes a problem, right? You can have open access articles where you can see the entire paper, and sometimes you don't have the full paper. So the resource is available is through the library. They do have access to several journals, at least ophthalmic journals, where you can get full text journals. Having said that, I think it is important for you all to read the whole paper, okay, not just the abstract, and develop cut and paste from that. To develop your IRB proposal or even to formulate your hypothesis. The other challenge that comes after reading, sometimes everything is jumbled in your mind and you have a lot of things you've learned. How do you formulate and summarize this to get to the next step and really ask the question of the research gap? What's the knowledge gap? So that's critical to determine. Again, there are several levels of mentors available in research, and you could contact them, or they will provide you with other resources where you can help answer this question on how to summarize the literature, and more importantly, and identify what's new, right? when you do research, you want to do something new, not just it's the first study in the kingdom, maybe there's something newer than that, that you could contribute to the literature. So what is a hypothesis? Again, it's an assumption, an idea that is proposed as a question to see if it's true. So a hypothesis could be, is a primary tube better than a tap? So you formulate it as a question. And then figure out, is there a knowledge gap? And based on the knowledge gap, you develop this hypothesis. And like we said before, I'll repeat that, multiple advisors and research that could help you with that. So the design of the protocol for sometimes, once you have the question, can be challenging. And you'll hear about the different types of studies that can be done here at KKISH. And I think for this, this is a must. You have a lot of resources between your mentor, people in your department, people in education, but also in research, where you want to consult with for most projects, especially maybe not a case report or maybe not a case series, but at least to determine sample size, have clear study questions, and then base your methods based on your study questions and not go off track, and have the right data collection forms and form dummy tables, and I'm sure somebody would address that later on the talk. Once you have all of these things in place, this will really make your project go smoothly, okay? You need to have all this done prior to your study itself. And it's like, going to surgery, right? You go do surgery unless you have preoperative planning, right? And you understand what IOL you pick, the characteristics of the patients. If you have all of that, the likelihood of your surgery going well is reasonably good, right? So I think that planning is really important. So I think some things to understand about the IRB in the process, and I think one thing to remind all of you, the IRB doesn't report to anybody in this hospital. It's an independent entity, reports to the National Council of Bioethics, even though most of the members are employees of the hospital, staff here, but their jurisdiction over the ethical parts of the proposal are independent of the research department, okay? We don't interfere with that, nor should anybody do that. And so they are here to protect the patients and also protect us, as well as make sure we do beneficial and significant research. But having said that, the IRB staff is always available to navigate you through what look like complex forms, but are essential, and to make sure that you complete them properly before submission, and it doesn't go back and forth for you to revise it. And of course, that can be a frustrating process. So most of the projects that you do as a resident or fellow do not require funding, but there are exceptions. Sometimes you might be doing something on genetics, right? Or you might be decided to do something that's a basic science project, right? And those require money. And so sufficient planning, contacting the research department of potential funding sources is important. There are funds in research, but there is a process to getting those approved before you do projects that involve money. So you want to contact the Research Center for advice. And how do you recruit patients? Of course, you are assigned a clinical research coordinator. And all of them can help you with data collection forms, patient diagnosis from HIMD, and also help you in a prospective study to identify patients and help with scheduling. But you need to do something also for the study, correct? It's not all about the research staff. So I think the important things are correct data collecting, making sure that the data is cleaned, and I think people will explain to you what cleaning is meant later on in the talk. And then, of course, you come to the analytical stage. And we have really a remarkable resource for analysis in our biostatistics team. I can tell you, having worked in many institutions, this is not available freely to residents and fellows around the globe. So we do have that resource. But research department is there. Of course, it should be mentor-driven. Your mentor should drive this process. but the research department is to help. But there are certain caveats I want to point out to you, that there are, about 40 of you, right? And if all of you submit everything at the same time, it's not possible to meet the deadline, right? So beware of staff time constraints. Don't change protocol midway unless something is justified, and usually is not. Once you have decided the protocol, you don't decide to collect another set of patients, and don't collect and analyze data that was not approved by the IRB, okay? Just stick to your proposal. But I think the issue of staff constraints is important, okay? Not 2 weeks before you have to submit your thesis. That's not when you contact our biostatistics team to help you analyze that. So just beware of that. So once you come to manuscript preparation and submission for publication, there are several resources, I think somewhat underutilized at points. There is language, style, and editing available for language. We understand that most of you don't, English is not your first language, and so I think it's important that you utilize that resource. You might have the best data in the world, but if you don't present it correctly, most likely you're not going to get it in the literature, okay? And there you have your mentor and also the research department to help you with resources. And we're going to have most likely a brand new English language editing service who will also help you with journal selection and help you with the correct journal selection, and Dr. Malik can address that at some point. But we don't help with the submission process itself, but we're always available. Now, this often comes in a transition phase for you. You're graduating from a resident to a fellow, you've just finished your thesis, or from a fellow to becoming a consultant or going outside, and that submission process gets lost in translation. So I think it's important to realize that the research department is there to help you with that in many ways, and also the staff are available to help you respond to reviewers' comments if needed. So please use that resource. So once your research is published, make sure that you inform the research department so the project can be closed and recorded and move on to the next project. Thank you very much.
Okay, I'd like to introduce Ms. Sarah Harbi, who's our clinical research manager, to give the next talk.
Assalamu alaikum. Good evening, everyone, and thank you for attending this presentation. For my presentation here, I will just give you an overview of the services that we provide here at KCASH, and I will start off by highlighting the main sections that you need to be aware of in case you need certain help with anything. Now, the first section that I would love to talk about is the administrative section. It's a section that you can address if you have general questions or requests, or you need guidance regarding a specific or general help. Next is the Institutional Review Board. This is, of course, as we all know, this is the a committee that is independent, as Dr. Dibaka just mentioned. It's where you submit your projects and for review and approval based on ethical and scientific basis. And then we have the epidemiology section and the clinical section. These sections are mainly related to the design of your projects, the conduct of your study, and also the management and the handling of the data. And lastly, we have the Research Genetic Laboratory for services that is related to genetic studies. Now, here is a list of the support that we provided. This is not an inclusive list. So if you have any other questions related to the services that we provide, we can, of course, approach us anytime. First of all, I will talk about the safeguarding of subjects' well-being and rights according to the national and international guidelines. This is, of course, handled by the IRB committee. And then we can provide you with the calculation of the appropriate sample size that is acceptable for publication. And this is mainly for taken care of by the epidemiology section, and also the confirming of best study design suitable for achieving the aim of the study or the objective. Also, we assist in opening the research clinic, scheduling appointments, and obtaining informed consent form. We can help you screen for potential recruitment through a track care system or any other system that you might need. And then we have the performance of data coding and cleaning. We use different programs. For example, we use REDCap, SPSS, and Microsoft Office. And in this regard, I would highly recommend that you use the REDCap. This is for two main reasons. It has features that can help you be in control of the data entry and design, and also it's a user-friendly. So if you need to have training on this regard, we can help you anytime. Also, we help in performing the data analysis and assist the investigator in interpreting the analysis that they come up with at the end or the completion of their studies. We can also archive the research collected data. By the way, this is a main role for research here at KCASH, and we designed the questionnaire templates for survey-based studies. We act also as a liaison if you need with other departments in case you need it. We can provide also guidance and perform some genetic testing for certain projects. In addition to the previously mentioned services, we can also, and we do actually distribute list of recommended journals for publication. Mainly they are peer-reviewed journals and with high or good impact factor. And also we accept manuscript editing requests by investigators. We can also cover some of the research-related expenses and also the publication fees if certain conditions are met. At the end, we can help you with anything that you need from the start of your project until the end. And for any more information, you can also get in contact with us through the email here, or you can also visit us physically in our department. We welcome you anytime. So thank you.
Thank you, Ms. Sarah. I'd like to invite Dr. Hala to give the next talk on retrospective studies, case reports, and reviews.
Good afternoon, everyone. First, we'll talk about retrospective studies. These include retrospective cohort, case series, and case control studies. We know the level hierarchy of evidence, where the systematic review and meta-analysis lie in the above, and the case studies in the bottom. The retrospective cohort study, the characteristic of it, looks back in time, uses pre-existing secondary research data to examine the relationship between exposure and outcome. The data is usually collected after the outcome has already occurred. The case series, they are a collection of cases involving a novel or uncommon disease or treatment. Usually, when you write them, you describe the cases, not analyzing them. The case control study, the last one, identifies patient with and without the disease of interest. Then you compare the two group level of exposure to a potential risk factor in the past. The control participants are chosen similar to the cases in terms of specific traits, for example, age, comorbidity, severity of disease. The reporting guidelines, as requested by some journals, it follows a STROP, which is a 22 items checklist. You can find it online. We'll move to case report. They are detailed report of the symptoms, sign, diagnosis, treatment, and follow-up of an individual patient. They often describe an uncommon or novel event. Sometimes you can include literature review. It can provide feedback on clinical practice guidelines. It can offer a framework for early signs, signal of treatment effectiveness, adverse events, and cost. The topics of case report, it usually about either unexpected association between disease or symptom, unexpected event in the course of observing or treating a patient, It can report new findings that shed light on the possible pathogenesis of a disease or adverse event. It can present unique or rare features of a disease or a unique therapeutic approach. Why case report and case series lie in the bottom of hierarchy of clinical evidence? Because due to lack of statistical sampling. The advantages of case report, although they are the bottom of the hierarchy of evidence, it can facilitate recognition of new disease and adverse effects of treatment. It helps understand the clinical spectrum of rare disease and unusual presentations of common diseases. It can help generate study hypotheses. The reporting guidelines are, as requested by some journal, CARE for medical cases and SCARE for surgical cases. They are 13 or 14 item checklist. Finally, the reviews. It's important is raising. If you want to update your knowledge or generate guidelines about a topic, you can use a review article as a starting point. Its value is associated with what has been done, what has been found, and how these findings are presented. What is the purpose of writing reviews? Is to create readable synthesis of the best resource available in the literature for important research question or current area of research. The broad category of review articles: first, narrative reviews and systematic reviews. First, narrative reviews, usually it's written in easily readable format, allow consideration of the subject matter within a large spectrum, no consensus reporting guidelines available. On the other hand, systematic review requires focused question. Method must be clearly described. The ideal way to synthesize study is to perform a meta-analysis and should be written in a systematic fashion. The structure of a systematic review include introduction, where you present the problem and certain issue deal with the review article. The method, where you describe research and evaluation process, specific of number of study evaluated or selected. In the results section, you describe the quality and outcome of the selected studies. In discussion section, you summarize the results, the limitation, and the outcome of the procedure or the research. The steps of the systematic review: you start by formulating the research question. You disclose the studies, including the database you searched and the keyword you use. And later you go and evaluate these studies. And the last step is you interpret the method and you synthesize the outcome. How to determine the level or of the study you included? This is the table show that level 1 are the systematic review, which is the highest, and then randomized control study. Level 3, either non-randomized experimental study or observational studies such as cohort and case control study. The fourth level is case series. Meta-analysis, the aim of it is to derive conclusion with increased power and accuracy than what couldn't be able to achieve in individual studies. It is a quantitative review in which the clinical effectiveness is evaluated by calculating the weighted pooled estimate for intervention in at least 2 separate studies. The reporting guidelines, the famous one is PRISMA and MOSE for observational studies. The PRISMA is 27 item checklist and MOSE is 35 item checklist. You can find it also online. Thank you.
Okay, we have a few minutes for questions. If anybody has any questions for any of the speakers that have, Prof.
Thank you very much, Dr. Alwan. I have a question to our colleague, Ms. Sarah. She mentioned, and we all are aware that sometimes there are some availability of fund to cover some partial part of the publication fees sometimes, and so. So my question is whether there are some specific criteria on which basis that we can partially, fully support publication by one of our colleagues.
Yeah, so at the moment we don't have strict criteria whereby we reimburse the publication costs, but we're actually looking into that, and there probably will be criteria developed in the next few months. Ms. Sarah, would you like to add anything to that? Or?
We just have would like to just highlight some certain criteria regarding the journal. The journal to help you with the publication, it needs to be a peer-reviewed journal. This is what we recommend, and it also needs to be has a good impact factor, as I said in my presentation. Otherwise, we don't have other restrictions regarding publications.
Dr. Huda?
Thank you very much. This is very informative course. I have comment regarding the English editing. Sometimes when I send, they are very quick. I don't have any delay from their side, but sometimes I feel it's like proofreading rather than the complete editing. This is one question or a concern. But they are very helpful. Second, my second concern, I face difficulty with my residence thesis regarding finding the accurate diagnosis. It was a retrospective study, and I faced difficulty in the coding with HIMD, and I already we communicated with the IT with this regard. So I think we need to have accurate coding so we can have the process of the research smooth and not be delayed. Thank you.
Regarding your second point, we completely agree with you. You know, the diagnosis is not always accurately coded within TrackCare, and that's a major problem when we come to research data. So that's something we're looking at, and it might be that we have to move into a more structured way of collecting TrackCare data to enable research in the future. Regarding your first point, few people have mentioned comments about the editing service, and we're actually looking to move our services onto a new editing service, which will actually provide editing English language support, journal support, and also help with the submission process. So I'm hoping that you'll notice an improvement in the next few months. So as we're running ahead of time, I'm going to invite Dr. Kabir to give the next talk on epidemiological studies and surveys.
Okay, thank you so much, Dr. Rizwan, for organizing this course, and all the participants and the faculty who are participating in it. So the learning objectives of this talk is, by the end of this session, participants should be able to define what constitutes observational study designs, what are the advantages and the disadvantages of different study designs, what is prevalence and how it is calculated, what is absolute risk and how it is calculated, what is relative risk and what is odds ratio, and when to use odds ratios and when to use relative risk, and when to use them interchangeably. So these are some of the concepts that will be covered. And some of this will be some home tasks also. So this figure from the Lancet, you know, this is a very fundamental concept in epidemiology with regard to the classification of study designs, like who assigns the exposure. And that's important. Did investigator assign exposure, or was the investigator only monitoring it? So this part will be covered by my talk, this part. This belongs to Dr. Rizwan. So this is important. And one of the misconceptions we have is like experimental studies are important, observational studies are not important. And just because there's evidence of hierarchy does not mean that those studies are not important. So this is the design of a simple cross-sectional study, which involves around, so there is a population of a country of which we have sampled 2,000 people. And we want the aim of the study is to find out the prevalence of blindness. And this hypothetical study found that out of 2,000 people, 20 were blind, okay, using WHO's definition, which means that 1% of the population is blind. So one of the take-home message from these boxes, when you are making these boxes, when you are making a study design for a cross-sectional study, it does not have any direction, So just keep this in mind. There should be no arrows, just simple lines. This is a more complex cross-sectional design, okay, analytical design, where the sample size, again, is 2,000. And in this hypothetical population, 1,000 people have been sampled from urban, 1,000 from rural, and then the prevalence of blindness is 1% in urban, 1% in rural. It's almost similar. There's this, same. In Arabic, you call it same. So cross-sectional studies are used to establish the relationship between an exposure and an outcome. The outcome in this case is blindness. The exposure is urban-rural, where the person is living. And this can be male, and this can be female, this can be smoker, non-smoker, and the outcome is. So what is this is an example from a cross-sectional study. This is the National Survey of Pakistan 2003. And they took a sample of 16,500 adults from all over Pakistan, and they found that 2.7% people in Pakistan, of adults in Pakistan, are blind. And they found some disparities. 3.8% people in the rural area compared with 2.5% people in the urban area were blind. And this was statistically significant. So the whole basis of doing cross-sectional studies they are very, very important. These surveys are important for planning. In my next slide, I'll show you how important they are. Your entire health planning is based on these cross-sectional studies. Okay, budgeting, budgetary allocation, monitoring, evaluation progress, all this is based on, and unfortunately, as I have mentioned, I have heard many people say that these studies are not important. So, and it is not simple to do cross-sectional studies. What makes these studies important is the research question and how will you do it. So that's the fundamental issue with any design. The research question is important, and how will you conduct the study, and how will you interpret, how will you do the analysis, and how will you interpret the findings. So what is the key limitation of a cross-sectional design? When you are establishing a relationship between an exposure and an outcome, cross-sectional studies are not the best design. because they cannot establish a temporal association, the temporality. And for example, in this case, a cross-sectional study design might find a link between low vitamin D level and cataract. However, it cannot tell whether low vitamin D came first or the cataract came first. It can be a coincidental finding. There may be no direct link between the two. To establish temporality, researcher needs to do cohort studies where they follow up people who are unexposed, who have low vitamin D, and who have adequate vitamin D, and they are followed up for 10 years or 15 or 20 years, and only then they can establish a temporal association. Or use some other study design. Okay, so as I mentioned, like cohort studies are very important from the perspective of establishing temporality. And you need some? Okay.
Sorry. You can use this.
Okay, thank you. Yeah, okay, good. So what is the defining characteristic of a cohort study? A cohort study has follow-up. And the defining characteristic of a cohort study is, oh no, it's not. It takes people forward from exposure to outcome. So here, you have the exposed group and you have the unexposed group. And both are followed over time. And some of the people in this group will develop disease and some will not. And some in this group will develop disease and some will not. So what is risk or incidence? This is the definition of risk or incidence. So how to calculate relative risk? This is a very famous example from my disk. I'll show you how. So a study followed 500 coffee drinkers and 1,500 non-coffee drinkers who were aged 40 years, more than 40 years, and they were not hypertensive at baseline. And they were followed for 1 year. Hypertension developed in 50 coffee drinkers and 150 non-coffee drinkers during the follow-up period. The follow-up period is 1 year. And this is the 2x2 table. So the risk is calculated in one group. For example, the risk of hypertension in this group is 0.1. And in this is 0.1. And what is the relative risk? 0.1 in one group divided by 0.1. It is same. It is 1. 1 means the risk in the two groups is similar. So this is one of the, when I was doing my PhD, you can see the coffee, 4 cups of coffee by lunchtime, and there is an anti-acid here, 8 or 9 drafts of, this is a take-home message for the residents to revise your draft, like this is 8 or 9 drafts. A consultant, when I had some neck pain, and the consultant, a neurosurgeon, came and just tried to elevate my screen with this. So I always used this, or our annual reports to elevate my screen. And one thing is missing is the analgesic balm. You know, in order to write so much, you need to have that kind of. So the next example is smoking. Is smoking associated with coronary heart disease? So results of a 10-year cohort study of smoking and coronary heart disease are shown below. What was the relative risk of developing CHD in smokers compared to non-smokers? So the first step is you calculate. You start here. There are three. You start here. You calculate the risk in the exposed group, and then you calculate the risk of coronary heart disease in unexposed group, and then you divide the risk in exposed by the risk in unexposed, and what is the result? 1.75. So how would you interpret it? Can anyone interpret it? Yes, please. Yeah. Risk is higher? Okay, excellent. So exposed are almost two times more likely to develop coronary heart disease over 10 years compared with non-smokers. This is the third example. This is the example from a flu vaccine trial. Okay, a study investigated the effectiveness of flu vaccine in preventing influenza. A total of 500 vaccinated individuals and 500 unvaccinated individuals were followed for 1 year. By the end of the study, 50 vaccinated individuals and 150 unvaccinated individuals developed the flu. Okay, so let's calculate the relative risk. So what does the relative risk show? 0.33. It shows that the vaccine is working. It is protecting. So those who are vaccinated are 3 times less likely to have flu compared with those who are unvaccinated over 1 year. This over 1 year is important. So this is a recap of what we did, like whether the risk is the same, though then it is the relative risk is 1. If it is more than 1, that means the exposed group is more likely to develop the disease. If the risk RR is less than 1, like I showed you the example of flu vaccine, that means the vaccine is working, it is protective. Okay, this is the design of a case control study. And as you can see, the direction of, this is very important, like, so the starting point in a case control study is you start with cases, as Dr. Hala said, and then you select controls. And then you find out who was exposed and who was not exposed. The same in this group. You ask about the exposure history and who was a smoker and who was not a smoker. So what is the commonest limitation of a case control study? The commonest. There will be a special prize from my side for them. Confounders are, okay, good, very nice, but confounders are a problem in every study. So you have to control for it. Okay, excellent. So recall bias. Recall bias is, okay. So recall bias is cases are more likely to recall past events compared with controls. Okay, what? Okay. Yeah, retrospective study. that means you have all these problems, recall. Okay. So, comparing them directly. Yeah, but in all other studies, two different groups are being compared, right? Okay, so who won the prize? Me. Okay. 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 So this is crossover. Like for example, so for that period, a person was okay. Okay. The biggest problem in a case control study is the selection of controls. And there is a whole Lancet article focused on this, like how important it is to control, to select the right controls. Hmm? You have to give me the prize. No, this was about crossover. So this is how you calculate the odds ratios. So the starting point is this, right? You out of 225 cases, you have 150 who are exposed, right? So for every 150 exposed, there are 75 exposed, non-exposed. Among controls, for 150 exposed, 300 are unexposed. Okay, you calculate the odds among the odds of exposure among cases is calculated first, then the odds of exposure among controls is calculated, and then the odds ratio is calculated. So you can calculate it like this. This is the interpretation. So a very important quotation from this one of my favorite articles, and it's a must read. And one of the giants of epidemiology, he says that he would trust only 6 people in the world to do a proper case control study. And this is from Rothman, Kenneth Rothman, who is also a very well-known figure in epidemiology. So read this. So the take-home message from them is never take it lightly. It's also, it's a very serious effort. So when is odds ratio a good estimate of relative risk? If these assumptions are fulfilled, then both of them can be used interchangeably. Otherwise, not. And thank you very much. Thank you for all your patient listening.
Thank you, Dr. Kabir. So we're going to break in a minute, but does anyone have any questions for Dr. Kabir that they have before we break?
Thanks, Dr. Kabir. So if I were a trainee and I wanted to look at, the blindness rate in children coming to our hospital, right? And would a cross-sectional study be appropriate? I guess I'm asking, let me put it in another way. Can a cross-sectional study be retrospective, or does it always need to be prospective?
Okay, so cross-sectional study, no. Because the prevalence, the incidence is so low. So maybe there is some surveillance system where all children who are blind in a country at a certain time, if they're captured, then, but for like the prevalence of blindness is 1 out of 50,000. So it is, it's not a good design for cross-sectional studies, are not good design for childhood blindness studies.
I mean, looking for it in a hospital setting, right? So how many blind are there in a retrospective manner?
Yeah.
Is that an appropriate design, or cross-sectional, or something else that can be used for
So it's a case series. It's a case series. What you have received is a case series, but it can be, you know, if you have information, assuming everyone from the population is coming, then, you know, it can be extrapolated to the, if all cases.
So I'm assuming we see, you know, in 5 years we've seen 100,000 children for various diseases, but X number qualified as, or could be labeled as
Yeah.
WHO standards of blindness.
Yeah,
So
yeah, so this will be the frequency of blindness among all those who presented to KKH with different eye problems.
And I guess since we're looking at, because I think one of the things, time is an important thing in a cross-section. You're taking a cross-section, right?
Yeah.
So do you need to, if you're defining a study like that, define a time period
Yeah.
so that you can calculate the rate? Would that be important also?
Yeah, rate is important. Like, for example, who is developing disease over time. So, yes.
And the second is related to both relative risk and odds ratio. You know, the number can be anywhere from, you know, 0 to infinity, right? The changes.
Correct.
So
Correct.
when that number comes closer to 1, let's say
Yeah.
0.9, 1.1, 1.05, how do we decide that this is important as an interpretation or not?
Good.
Or is it basically based, depends on the person or the clinical judgment or whatever it is?
Yeah.
Is 1.1 better than 1.2? It looks like it, but where is the cutoff, or is there any cutoff?
This is a very, very good question. Odds ratio tend to overestimate the relative risk. I give you the example of one of my former resident. He came to me, and without telling me, like, he said that he needs odds ratio, and he wants to establish an association between an exposure and outcome or a treatment. I calculated the odds ratio for him, and 2.5 for 3 different factors, and all significant. And I went home and, you know, started thinking about it, like, I've not done a good job, because it involved follow-up. You know, we should calculate the relative risk. And when I calculated the relative risk, it was around 1.1 and not significant, 1.2, 1. So it turned out to be insignificant. And the residents were so upset. I was happy, as usual, but the resident got so upset. And so that's important. You know, a fundamental issue here is, like, how large is the population? Like, if, you know, a relative risk is 1.2 or 1.3 times, and that's what should ideally be, 1.2, 1.3, and if it involves a large population, then it's and if it's significant, then it's an issue. But for a small sample size, even if it is 200 or 300, so I would be very cautious about it, and no decision should be made based on small sample sizes.
Thank you.
Thank you.
Okay, thank you very much. So we'll have a break now, and we'll reconvene at 2:05, please. Thank you.
Oh, it is
Yeah,
working.
it is working, but it's
Yeah.
not very loud. It needs to be louder, right?
Oh, slow.
Okay, so we'll recommence now, and we'll start talking about a third design of study of clinical trials. So what is a clinical trial? Well, a clinical trial is a research study that tests new treatments, drugs, or medical devices. And the aim of such a study is to test the safety or effectiveness of a new intervention. Now, in simple terms, a clinical trial is a research involving people, usually. It tests a health-related intervention and outcome, and it answers questions like, is the intervention safe? Does the intervention improve or cure disease? Or does it help people feel better? Now, although we think about clinical trials as drug trials, there can be different interventions that we look at, such as devices, surgery, and diet and lifestyle. One of the fundamental principles governing clinical trials is that of clinical equipoise. What clinical equipoise means is there has to be genuine uncertainty that the treatment works. Now, can anyone tell me why there has to be uncertainty that the treatment actually works? Or uncertainty between two treatments in order to carry out a clinical trial? If one treatment is better than another one, is it ethical to do a clinical trial? So if one treatment is better than another one, and it's been shown that, it's not ethical to do a clinical trial because, first of all, it's a waste of expense and time, and second of all, it's unethical to randomize patients to a treatment which is inferior, right, because of safety concerns and so on. So this is an important principle, clinical equipoise, which governs the underlying principle of carrying out a clinical trial. Now, it's interesting that the first recorded clinical trial was done by James Lind, who was a Scottish sailor. And what he noticed was sailors developed a condition known as scurvy due to lack of vitamin C. And he had an idea that this was due to lack of vitamin C. So what he did was he assigned some of the sailors to have a diet which was rich in citrus fruits, and another group of sailors who had a normal diet. And what he found was that the sailors who had a diet rich in citrus fruits didn't develop scurvy, and he published his findings. So this is the first documented clinical trial. Now, clinical trials have come a long way since then. And interesting, there's a story in the Bible, in the book of Daniel, where it was believed that a diet which was rich in meat and wine made you more handsome. So what he did was he went on a diet consisting of water and beans, and it was a few of them went on this diet, and they actually turned out looking better than the ones who were taking meat and wine. These clinical trials have come a long way, and really the ethical code for clinical trials really developed after the Second World War in about 1947, and the modern kind of ICH guidelines from GCP have been implemented since about 1997. And we'll have some GCP training, which is very relevant to this, later on this month. So please all register for that if you haven't. Now, like Dr. Hala alluded to in a previous talk, clinical trials actually form a hierarchy of evidence. So they're important source at a high level of clinical evidence, and that's why they're important. There are various components to clinical trial, and the main components are having participants to take part in the trial, having an established protocol, investigators that lead the trial, and having a defined outcome measure. So what is a clinical trial? Well, let's think of a clinical trial where we look at a drop A, a new drop, and we want to test whether it's better than timolol at reducing eye pressure. So we have a hypothesis, and Dr. Deepak talked about hypothesis earlier on, and the hypothesis is that drop A is superior than timolol at reducing IOP. So what do? We take a population, we define our inclusion criteria, and we randomize the group to receive drop A, and we randomize a second lot of the group, half the group, to receive the standard treatment, which is timolol, and we decide on an outcome measure. And we measure their pressure, and we decide which drop is better. So here we've looked at intraocular pressure as an outcome measure, as a measure of effectiveness. We could also be looking at safety. We could also be looking at cost. So these are different outcome measures we can use in a trial. Now, this is a simple design of trial I've mentioned here, but there are other designs of trials, and some are quite complicated. Some trials are non-randomized. Some are cluster randomized. What that means is groups of people are randomized to a treatment rather than individuals. And that might be schools, for instance, or it might be villages that are randomized to a certain treatment. So what are the advantages of trials? Well, we've said clinical trials forms a high level of hierarchical evidence. It establishes a causal relationship between an intervention and an outcome. It has an unbiased distribution of confounders, and I'll talk about confounders in a minute. And you can blind. So you can blind the person who is assessing the outcome, you can blind the patients, and you can also blind the doctors. In clinical trials of ophthalmology, we tend to talk about masking rather than blinding, so not to get confused with vision loss. And because we randomize treatments with an intervention arm and a control arm, the baseline factors are balanced out between the two arms, and therefore statistical analysis is much simpler because the two groups are very comparable. Clinical trials have disadvantages. They're expensive, they take time, and there's something known as volunteer bias, because the people who volunteer for clinical trials tend to be a super normal population. Okay, they're not the people that take part in everyday studies. They're people that are motivated, and they might have different characteristics than other patients. So that can be a problem. Clinical trial data is not always real-world data that we see every day. Clinical trials can cause ethical concerns. Like we said, if one treatment might be better than another one, it might be unethical to randomize people to an inferior treatment. Now, in terms of drug development, device development, the different phases of clinical trials, and these are usually characterized in terms of 4 phases. And these are characterized according to the type of the study and also the number of people involved in the study. So preclinical trials usually involve animals before the drug is tested on humans. Phase 1 trials involve healthy volunteers of about 20 to 80 subjects to test safety and pharmacodynamics. Phase 2 trials are usually randomized controlled trials with a placebo and test adverse effect and efficacy. And phase 3 trials involve hundreds to thousands of participants, which are usually large RCTs of efficacy in a larger number of people. After FDA approval, we then go on to post-marketing trials. Now, we've talked about drug trials and treatment trials, but we can also have prevention trials or screening trials. We can also assess behavior, how different behaviors affect a particular outcome. So they don't have to be necessarily treatment trials that we look at. Now, an important aspect of clinical trial methodology is a control intervention. And what that means is you have an active treatment and you have a control treatment known as a placebo usually. Now here you can see there is a control treatment and an active treatment. But can anyone see what might be the problem with this kind of trial? Sorry? Yeah, so you can see that the placebo looks different to the active drug, right? So if patients were assigned this treatment, they would know that they're not receiving the active drug, that might affect their behavior and it might affect the outcome of the study. So a placebo treatment has to look, feel, taste the same way as much as possible as the active drug. Because there's something known as a placebo effect. Okay, patients in a blood pressure trial who are taking a placebo actually have been known to have a reduction in blood pressure from placebo. So there is a placebo effect. And in fact, in the UK GTS study, which is a large randomized study of eye drops for intraocular pressure lowering, patients who were randomized to have placebo drop were found to have a slight reduction in intraocular pressure. So this is an important effect that needs to be considered. We talked about confounding earlier, and I'd just like to illustrate this with this example. So say we're looking at a study looking at the effect of coffee on cancer. So coffee is the exposure and cancer is the outcome. And we find a positive relationship. So people who drink more coffee get more cancer. But people who drink more coffee are also more likely to smoke. Okay? So the effect actually is smoking causing the cancer rather than coffee causing the cancer. And if you don't consider these confounders, you'll develop incorrect conclusions from your clinical trial. Now, one of the advantages of clinical trials is because of randomization, you overcome some of the confounding factors. So say we have a population, and here the green man is an individual with a confounding variable, and you randomize half to intervention and half to control. Because you've randomized the groups, you've balanced out the confounding variables between the two groups, and the two groups are comparable. One of the other important methodological criteria for trials is masking or blinding, like we mentioned. So you can mask patients to which treatment they're having, you can mask the doctor to which treatment the patient's having, and you can also mask the person who is doing the outcome assessment as to which treatment the patients have been given. And that's important because patients, if they believe they're having an active drug, they might be more motivated to get better, and doctors might have motivation to see a new treatment working better, so their behavior might change as well. So it's important to mask, double mask or even triple mask whenever possible. Can anyone think of circumstances where you may not be able to mask? So, yes? Exactly. So if you do a surgical intervention, you're comparing it to, if you might be comparing it to a standard surgical intervention, then you can. But if you're comparing it to a medical intervention, then obviously the patient's going to know whether they're receiving a medication or they're receiving surgery, and it's very difficult to mask either the patient or the doctor in that particular situation. So safety is of prime concern in any research study or clinical trial at every step, including when you plan the study, you must have safety considerations, ethical considerations, and after you undertake the study, you must report any adverse events. And most clinical trials would have a data and safety monitoring committee to monitor any adverse events during the trial. Informed consent must be undertaken for every patient. Again, this will be covered in the GCP training. Consent is voluntary for all participants and can be withdrawn at any time, and this should be stated in the consent form. And consent is an ongoing process. Now, participants can withdraw consent at any time during the trial, and it shouldn't affect their care. So in summary, clinical trials provide robust evidence on efficacy or safety of a drug or new intervention. Randomization, placebo, and masking are important considerations of clinical trials. And the safety of participants should be ensured at every stage of the trial. Okay, thank you very much. Okay. I'd like to invite Dr. Khalid to give the next talk. Thank you.
Bismillah. Okay, so this presentation is to explain the different types of research which might be conducted or you might be come across. Type of research, there are lots of confusion sometimes in terms of people calling applied research basic research, or they are calling clinical research as a basic research. So what are the differences? Basic research, usually it's a type of research which goes into understanding the mechanism of how things work, for example. Okay, so if we want to know how a gene contributes to the pathogenesis of a certain disease, I would call that basic research. If I want to see how atoms comes together to formulate a molecule, that's a basic research. Okay. Applied research, on the other hand, it's sort of a research which comes after the basic research. So after the fact has been established, the scientific fact has been established, an outcome came out of the basic research, and that outcome, I'm using it to apply for a certain research study. I'll give an example. If I'm like a known genetic mutation or a known single nucleotide polymorphism which has been associated with a certain disease. So I take a group of patients, I take a group of controls, and then I compare and see whether that mutation or that SNP is actually associated with the disease. Here, I'm not trying to understand how the mutation caused the disease or how the mutation contribute to the pathogenesis of the disease. Here, I'm just merely evaluating whether that particular SNP will be used as a marker for the disease or not. Now, clinical research, on the other hand, is actually a type of research where there is a patient, okay? So clinical research can also be applied research, okay? And so this research terminology or different types of research can overlap, okay? Industrial research, as the name indicates, this is based in industry, okay? And academic research usually is carried out at academic institutes like universities and so on. And translational research, which is, we will talk more about that. Translational research can be classified also as an applied research. This type of research is used to translate knowledge from bench to bedside. So it is something where you can translate it into an effective either treatment or diagnostics and so on. So this type, it's very important to understand this, the variability between different types of research, because usually the objectives are different. The location where you conduct the research is different. The aims are different. The budget could be different. The duration, the target out of the research, the output. So it's very important to understand the various types of research and what they mean. For example, for our institute, the research center can be classified as applied research because we are a research center attached to a hospital. Now, if you want to do a basic research, maybe you conduct a collaboration with the university and so on, okay? And so applied research is more applicable to in hospital settings where you can actually benefit the patient population out of your research, and you don't have to wait for years in order to translate your findings into an effective diagnostic or treatment regimen. So translational research In healthcare, as the statement define it here, it's the process of turning a scientific discoveries or a finding made in the lab into a practical application which improve human health and well-being. Good example, for example, from the genetics point of view, it's pharmacogenomics. Okay, I'm evaluating certain medication, and I find that certain individuals with certain genetic makeup can respond to a certain treatment in a much better way than other patients. So this is a good example of something you can translate from the lab to the from the bench to the bedside. What's the key aspects of translational research in healthcare? We talked about bench to bedside, and you translate the findings from basic science into clinical trials and therapies. The second advantage, it's multidisciplinary approach where you involve collaboration among scientists, clinicians, eventually industry, if it's a good idea, which can be commercialized in economy-based type of research. And you combine the expertise of people with different backgrounds, like in biology, medicine, engineering, and maybe AI and data sciences. One of the key aspects also of translational research, it's a patient-centered focus. And in a hospital settings, that might be actually ideal type of research to actually employ. The stages of the translation, usually stage one, where basic research turn into clinical research. Like, for example, here, developing a new drug. And the second phase is actually clinical research to practice. You implement a new treatment. We give an example of the pharmacogenomics. And three, you practice to population health, like you can use it for screening populations and so on, and ensuring the widespread adoption and monitoring the impact on the healthcare system as a whole. This is point number 5, the impact on healthcare system. You accelerate the development of therapies, and you reduce the time and the cost involved in order to translate science from bench to bedside. Aims of translational research in healthcare is basically improving the health outcome, okay, and promoting health equity, economic advantages, usually in countries where they use research or applied or translational research to generate income and create a cost-effective solution, which on the overall reduce the cost of patient care. Environmental impact, support the development of green technologies in medicine, encourage substantial practices in pharmaceutical production and waste management, and global health security, enhance preparedness for pandemic and emerging diseases, and strengthening the healthcare infrastructure in low resources setting. So what are the challenges in translational research? Limited resources, okay? Sometimes the resources are limited to actually apply what you want to study. Lengthy approval processes. Sometimes you go through scientific committee, IRB, and so on, and these things can take actually time, and especially if you are actually seeking funding, that could take a considerable amount of time. Collaboration barriers, this is usually between academia and industry, and sometimes the situation is not as straightforward, where industry They demand sometimes more from academia, and academia want to have a stake in the production or in the final product. And here you might have like legal challenges and so on. Ethical concerns, balancing innovation and society impact. So you have to take care of these situations. And clearly from the problems, strategies to strengthen translational research, you need to increase funding, foster collaboration between industry, academia, and research center attached to hospitals and various research centers, and industry, business people, and so on. Streamline regulation, make it, practical regulation, make it easy for people who want to do translational research to actually do it in a manner which is ethical, beneficial to the society and to the institute they represent. Public engagement, you build the trust and awareness about the benefits of science in the society. And basically, I think in Saudi Arabia in particular now, there is a huge emphasis on translational research. Before, research was done like basic research where most of the studies were like left on the shelves, no benefits to the patient community. So I think now the general policies and standard is to actually promote translational research, and in order to have a quick impact on the health and well-being of the society, and of course substantial savings on patient care cost. Thank you very much.
Thank you very much. So Dr. Ahmed Musa will give the next talk. So when you're developing your research proposals, you'll need input of the biostatistician at two stages. One, when you're planning your research for the sample size calculation and the analysis plan. And then later on, when you finish your data collection, you'll need it to analyze the data. So now Dr. Ahmed is going to talk about sample size considerations first.
Bismillah ar-Rahman ar-Rahim. So my colleagues, I always hear from our colleagues, the clinicians, that they don't like statistics so much. And I can answer you after many years of working in this field is that the reason is when you talk to a statistician, he's always providing you with equations and you see sigma, epsilon, something like this going around. But the issue is if you just take it step by step as a simple way and as an essential way actually to conduct your research and end up by a concrete evidence, you will find it very simple and easy to go with. So two major issues we usually talk about while applying for our IRP is the sample size calculation, the sampling procedure, and the selection of the most proper study design. So there are some simple considerations when you try to calculate your sample size. As we all know that we cannot recruit the whole community, so we select a group of the community. This group of community should have two main characteristics. It should be very representative to the community, so once you end up by analyzing the data, you can generalize your findings to the whole community. And it should be actually including all the categories that you may find affected within the community. So very simply, if I'm targeting a population, I always in the IRP, we put two items. What is your target population and what is your sample size? So the study population, very simply, is the whole frame. And then the target population is, let's give a quick example, is patients with glaucoma, for example. And then the sample will be patients with glaucoma and they have went through deep sclerectomy, for example. So by this, you are targeting a sample that is representative to your study population and ending up by representing the whole community, which is almost there. So while recruiting your sample, actually, you should make sure that the sample is having all or the majority of the characteristics of the population. Not only that, but that findings can be generalized. Let's imagine that we took a piece like this, a slice of the community, and then we applied our research on this group of people. It's not only important that you take a representative sample, but it is also very important that when you end up by conclusion, it can be reflected to the whole. So there are two main types of sample size calculation. One is so-called the probability sampling, and the other one is called the non-probability sampling. To cut it short, we don't use in medical studies what is so-called non-probability sampling, because as you can see, it consists of judgment, quota sampling, and purposes sampling, and this is most probably used in social sciences. So in medical biostatistics, we use the random sampling, we use the cluster sampling, we use the stratified sampling, the multi-stage sampling, and the systemic sampling. So to make it very easy, random sampling is a sampling process where you give each and everyone in the community the same probability to appear in your sample. This is what we call the random sample, the simple random sample, sorry. Systematic sampling means that you select blocks, like I take the first household, I leave 3 households, I take the 5th household, I leave 3 households. This is what we call blocks. Do we apply this in patients? Yes, we apply this in patients, and we apply it even in clinical trials. Like if I'm going to conduct or compare to surgical procedures, I can take every 5th patient that appears to the OR. So what is stratified sampling? Stratified sampling means that my population is having or consists of different strata. As the example given by Dr. Khabir, that you have rural and urban, you have males and females, you have older people, you have younger people. This we call strata. So we have to represent the whole strata in our sample, so we divide our sample to capture the strata. The cluster sampling is something totally different. Cluster means I take the whole group. I take a number of households that in one block and examine them all or conduct my intervention to them all. So there are some major issues that we should consider also while doing our sample size calculation. For example, one of the very quite common issues that happen, that you have a rare disease. Okay, and you want to capture this rare disease very simply. But the problem which is going to face you if you have, for example, a case control study or a cohort study, where both studies have cases and controls, that you will face difficulty in finding association, because you have like 3 to 4, 5 cases in one arm, you have 100 cases in the other arm. So there is a difficulty to get evidence, because the p-value will be diluted in this case. So some of the considerations we take in is we look at the type of study design we are trying, which significance level, which power level, and which is the expected prevalence of the disease. If we look at this, we can reconsider sample size calculation. So can I change the significance level in my p-value? Yes, I can change it up and down as much as I can. But I should put into consideration, if you increase your significance level, for example, instead of what's so common to us, 95%, if you make it 99%, then your sample size will shoot high. The power is the same thing. Power, we usually take commonly 80% as power, as it is the opposite or the integration with the beta error. And if we want to increase the power of a study, means that we are increasing the level of evidence, we will face another problem because we will need to increase the sample size. So another issue is if I am conducting a study, let's say, and I'm including two diseases in the same study. For example, I'm including cataract and diabetic retinopathy in the same study. So my problem here is the prevalence of cataract is high, but the prevalence of diabetic retinopathy is lower. So I design my sampling to capture both diseases in the same time. So now can we add some other considerations? Yes. If I know that the response rate in my study, for example, I am disseminating a questionnaire, and I am not sure if the response rate will be very high to my questionnaire. So I need to account for the expected response rate. If I am expecting a high number of dropouts, for example, I'm conducting a glaucoma surgery and I need to have a very long follow-up time. So I highly anticipate that I will have drop-downs. So I account for those drop-downs from my study. Or if I have a lack of compliance, again, if I'm giving drug, and I know that, like, again, glaucoma drugs, usually patients are uncompliant, so I have also to put this into consideration and put a marginal, safe marginal addition to my sample size. Means that I calculate the sample size and I add 10% contingency to account for the dropouts, to account for incompliance, and to account for other factors. So I end up by having the target sample size. So there is a big difference between simple random sampling, where I give the whole community the same opportunity to appear in my sample, and utilization of other types of sampling, the systematic, the stratified, and so on. So one of the main biostatisticians, Professor Kish, he actually introduced what is so-called the design effect. So when we go for example, some of us would go for open sources for calculating the sample size, the online open sources for calculation. And they face the problem that what is the D? They ask them to put the D. So the D is the Kish effect, which adjusts between random sample and utilization of other types of sample to make it equal to simple random sampling in terms of achieving the required sample size. Another very important thing is when you conduct a clinical trial, for example, you are conducting a clinical trial and you have several arms. Like Dr. Malik introduced 2 arms and 3 arms. Sometimes some of the clinical trials may be more. So how can I account for having different arms? Here comes what is so-called the Bonferroni correction to adjust between your different arms according to different interventions. For example, you can have intervention A, intervention B. You can have placebo, intervention A, intervention B. And you can have 3 interventions plus a placebo. This would dilute the evidence. So to correct this evidence, we use what is so-called Bonferroni correction. There is also always a debate between the epidemiologist and the clinician. The clinician would say, I have what is so-called the clinical significance. The epidemiologist would say, I have what is so-called the epidemiologic significance. So what is the difference between those 2 terms? The issue is simply that you are a glaucoma surgeon and I am ocular epidemiologist. So I tell you that if you reduce the IOP by 10 millimeters mercury, and I do my calculations, I give you evidence that the p-value is significant. This is what we call the epidemiologic significance, because numbers are giving me significance. However, the glaucoma surgeon would say, no, this is not clinical significance. It would be a clinical significance to me if the IOP is decreased by 15 to 20 millimeters mercury. So what happens between the epidemiologist and the clinician? They should sit together a priori and decide what will be the threshold of accepting what is so-called a significant difference among groups. So we should keep in mind before applying that each type of study design, case control, cohort study, clinical trial, meta-analysis, each type has its own way and equations and approach in calculating sample size. It's not the same thing. This is why if you look at the websites that enables calculation, you will find put your study design first and be sure, is it case control, is it a cohort study, is it a clinical trial? Because the website in the background is going to change the equation of calculation to suit your type of study design. Let's get back a bit on the major types. The case control study, we know that we sample based on the outcome, okay? And in cohort study, we sample based on the exposure. What has this to do a relationship with sample size calculation? Because the considerations of calculations will change. This is to give you an idea why the calculations change between case controls and sample size. By the way, wanted to give you a quick hint about how much control should be in a study design. What do you think in your mind that a control should be, other than being matching the cases? So the definition is it is matching with cases in terms of all characteristics except for the disease. This is the definition of control. So what would be the ratio from your viewpoint? How do you think the ratio should be between cases and controls? Any suggestion? Okay, do you think it should be 1-to-1? So how many of you would think it should be 1-to-1? Okay, great. So the case to control ratio can start from being 1-to-1. At least the controls should be not less than the cases. However, it can be 1-to-2, it can be 1-to-3, it can be 1-to-4, given that the lower number is the cases, not the controls. Because as much as you increase the control, you get better evidence. So I can go with this forever? No. It was found by studies that the maximum number is 1-to-4. If you exceed it more than this, you get very, very, very normal people which will not get you any evidence about anything. One of the major questions when I recruit my cases, I recruit them based on what we call the individual, the item of analysis, the analysis item. So as we are ophthalmologists, sometimes we need to recruit our cases based on person who has 2 eyes or based on the eye. Sometimes if I'm doing surgical intervention, of course, I'm not looking at the person because the disease of interest would be encountered by one eye. So I recruit eyes, not cases. So some researchers will say, okay, if I need control, I will take the other eye. Okay, the other eye we call as the best control for the intervention eye. This is true because you are now 100% sure that the same person having the same characteristics, okay? However, there is a high correlation between these characteristics. When you start to get associations later on with risk factors or so, there is a very high association between the 2 eyes. So you should consider this while doing the analysis to adjust for the high correlation level between the 2 eyes. So before applying for the IRP, we need to make sure that we calculated the sample size. Not only that, but the sampling procedure, because the sampling procedure is something totally different from the sample size calculation. The sampling procedure means that how are you going to recruit the sample? You will use block, you will use sealed envelopes if it is a clinical trial. So sampling procedure is also as important as the sample size. Then you need to develop your analysis plan. One of the very important questions that we get asked, how do I develop an analysis plan? So developing an analysis plan actually comes from reviewing the literature. When you review the literature, you find out how did people go before in analyzing such type of data. And then you then get what you have and what they don't have, your additions, what you don't have, you want to do something more, you want to improve your analysis, and so on. And then you develop a plan as we see. So we start in our plan with the descriptive analysis and go for the inferential. The descriptive simply is you describe your data. The mean age of the sample was so, how many male, how many female, and so on. The inferential will go for 4 different stages. You may need only one stage, you may need 2, you may end up by using them all. So what we call the univariate analysis means that you are linking 2 variables, whether it is a difference, association, correlation, impact factor, or whatever. What we call the multivariate, when we link number of variables all together, x1, x2, x3, x4, with one dependent variable to measure the effect. There is also what we call the repeated measures. Let's say that, for example, you have a patient with increased intraocular pressure, and then you decide to do experiment, then you do repeated measures for the same patients. In this case, each patient by himself will have 4 to 5 readings, which should be accounted for. And finally, there is what is so-called the longitudinal analysis, when you follow up a cohort for a very long time, and then you account for several issues, repeated measures, it is the same person for a long time, several follow-up assessments, and so on. So we talked about this. Let's take a quick example. This is a quick example of the univariate analysis. The descriptive analysis, when we just describe our data. And this is another example of the univariate analysis, when we try here to find associations between different variables. But in the univariate, remember that we are linking 2 variables only together. Then is the third example of having a binary logistic regression, which can link several variables to one dependent variable to see how much it affected. In the repeated measures, we have 2 different things. We have what is so-called within subject analysis, because now I started to have repeated measures, like in the glucose curve, for example. And we have what's called between subjects. So we have within subject consistency. There is an internal correlationship or no. Or the blood pressure is just fluctuating and there is no rules. And we have what is so-called between subjects analysis. In the longitudinal studies, it's a specific type of studies when you need to follow up patients for a very long time, like the very famous Nottingham study, for example. So finally, we need to remember that we start by describe our sample in terms of demographics, and so then describe our diagnosis. I had patients with glaucoma, they have neovascular, they have uveitic, they have congenital glaucoma, and so on. And then start by providing an image on the baseline. The IOP, visual acuity, cup disc ratio, so was at the beginning was like that, and post-intervention it became like this. And then you can compare the pre to post, and you can assess the success rate, complete success, qualified success, and so on. You can compare groups, you can assess potential risk factors, assess the effect size, you can do survivorship analysis to see what is the rate of survival of a patient after a specific surgery. So I hope it was not very boring to you, and I really wish if you got any good information from it. Thank you very much. And again, we are always in the research department here to help you if you hesitant about anything. The best thing is to consult the research staff before you start that, not after you go into the research.
Thank you, Prof. So does anyone have any questions for Dr. Ahmed or any of the previous few speakers?
This is why I talked about the D value. What is the D value? What is the N value? What is the sigma? What is the epsilon? If you are not sure about what these symbols actually referring to, so it's better to, in this case, consult the research department. So one of the very good services in Kekish here actually is that when you submit the IRP, it goes first to the epidemiology section. So the issue is not the epidemiology section, and please be aware of this. The epidemiology section is not ever aiming to criticize your work. It is, the staff is trying to make your study sure that you are on the right track. So sometimes people will write that I'm running a core study. So the expertise, the epidemiologist will say, oh, my friend, be aware this is not a case control study according to your introduction and so. So feel free to consult, and anyways, if even you don't write your proposal, it will come to the epidemiology section first, which will give you whatever recommendation to help you end up by a publishable paper. No, Prof. Edward, you don't ask me.
Well, I was hoping you could briefly address another type of studies that is commonly done by our trainees, and that is, surveys or questionnaires, knowledge, attitude, perception type surveys. What are the critical elements should someone think about while designing a good questionnaire/survey type study?
First of all, let's distinguish between what is so-called the questionnaire and what is so-called the index. The index means like the visual functioning index, for example, the pain index. So it is a type of indices that has been validated, tested for reliability, and published, and you have a reference. If you bring it here, you should make sure that either you are applying it in English, or if you do translation, you should have revalidation. Now, if you have an idea that's brand new and you want to design your own questionnaire, there are two major issues. Either you go for Likert scale questionnaire, or you go for subdomains questionnaire, which have categories 1, 2, 3, 4, assessing something. So the major source, the treasure, the big treasure is the literature. You can get a questionnaire that was conducted even if in another topic, and then try to take the idea about how you are going to design yours. One more thing is the reviewer, for example, I am the reviewer, is going to immediately tell you, did you validate this questionnaire? In terms of what? Are you sure that your questionnaire is assessing exactly what it was planned for, or it is assessing something else? So to avoid this, you need to do two steps. One thing is you can get a panel of expertise and ask them if they can add, remove, or there is a repetition, redundancy or so. And second is you can apply it to a 20% of your sample to make sure that then you can test the consistency that it is valid. However, because our colleagues now would find it very easy to develop a questionnaire and send it by email, just be aware that this has its advantages and disadvantages also in terms of ending up by a publishable paper. You don't want to do a lot of effort, spend a lot of time, and then you end up by something that will not be published. Thank you.
Thank you, Dr. Ahmed. Now we're going to talk about the IRB process. So you'll all be, if you haven't already, you'll all be applying for IRB approval for your projects. So Ms. Sarah has kindly agreed to give us a talk on that. Thank you.
Thank you, Dr. Ridwan. Good afternoon, everyone. Today we talk briefly about the IRB. So what's the IRB? IRB, it's an institutional review board. It's an independent committee that will perform a critical oversight of all applied proposals, focusing on the ethical and scientific aspect of the research. Consists of the committee board and of the administrative office. The IRB committee is the first committee registered in the kingdom, in the Saudi Arabia of the National Committee of Bioethics, implementing the regulation and the law of the ethics on the research of the living culture. So, the IRB committee is committed on the safeguarding of the subject and the well-being and the rights of according to the international code and the national regulation authorities law, such as the Saudi FDA and the National Committee of Bioethics. Authorized to review, approve, disapprove, monitor, and also even the terminating of the study involving the subject in the hospital. So all the research should be submitting to the research office or the IRB office as a hard copy or even the soft copy as the emails of the IRB or IRB office. So the mandatory things before you conduct any human research should have a bioethics certificate or equivalent certificate, such as good clinical practice. The National Committee of Bioethics, you can be registered, it's free, it's online. You can be subjected by the sign up in the National Committee of Bioethics website. After the registration confirmation, you can get the modules. You have MCQ module about 18. After that, you should have a correct 14 answer. You can be retrying many times until you get the certificate. The certificate, it's valid for 3 years and it is without fee. So what's the IRB process? After you submitting your proposal, you should have 3 years and it is without fee. So what's the IRB process? After you submitting your proposal, you should have a reviewing primary by the IRB office. After complete all the requirements regarding the certificate and the confidentialities, you should be submitting to the research associate to have a primary review on this project. After that, it goes for 3 ways, even exempted, such as an article review, or be expedited if it is no conducting any harm or any subject for the patient, should be reviewed by the IRB chair, or will be got for full board committee. Full board committee usually for prospective study have a subject or have a clinical trials. So the IRB committee have even full approval or have major changes or minor changes that will be conducted on the change made it for the methodology. If it is minor changes, they will have after correcting by the investigator, it return back for the IRB chair and have the approval. Or it will be for the major changes could be conducted again for the IRB committee and reviewing by the full board. Or it will be disapproved. This is only conducted if it will be harm for the patient. So the IRB not have end his authorities until the approval. The IRB will be extended after the approval. So the approval of the IRB is mandatory before conduct any activity for the research, before starting collecting the data or anything. And you should, when you have an approval IRB, you submit an annual progress report for the IRB office. For any modification regarding the methods, the data collection sheet, the investigators, you should be submit that for the IRB. And the monitor for the active clinical trial, it's an important for the safety of the participant. That's all. Thank you. Yes, any minor changes or major changes should be informed the IRB. And after that, you get approval and start the changes. Any question? You should inform the IRB about the investigator you be add or remove regarding his contribution in this project. After that, you get an approval from the IRB.
So can I just add to that, if you want to add somebody to the project, that's okay, but they should have a definite contribution and a well-defined contribution. You can't just add, your friend just because you want to add him. And you have to justify what his role is going to be in the study. Okay, and as far as the PI goes, there should really only be one PI per site. You could have other co-investigators, and that's okay, but he needs to have a defined role and to be justified for the study.
Any question?
Okay, thank you. So we'll go ahead.
If I may add on this, the HIMD usually they don't refuse to give you the information, meaning the medical records. What they refuse is the medical records. However, if you ask about the number of cases, they should give you the number of cases, but not the medical records until you obtain the IRB approval. Yeah, this is related to the regulations and the safety and confidentiality of the patients. So until now, this is the best practice we can do. Maybe if you can come to our office, we can help you with this regard.
Yeah, come and see us if you're having any problems, and we'll try and fix it for you. Okay, thank you. So we'll take a prayer break now, and we'll reconvene at 3:35. Thank you. Okay, so we'll recommence now, and Dr. Deepak's going to talk about a very important topic, is how to write a paper.
Okay, well, do we have people outside, or maybe they're still enjoying the break? So anyway, so this topic is kind of culminates from you started off as an idea, you collected your data, IRB did everything for you, and there's analysis, and the question comes about how to eventually write a paper. But before I do that, I think I just wanted to review something which is sort of bridges between the mind of a reviewer, which Dr. Khalid will talk about, and what you should anticipate when you do a paper or even before it. And this is from a very interesting editorial published maybe about 15, 20 years ago by Catherine DeAngelis. She was the first woman editor of JAMA in 100 years. And she reflected on her time as the editor and what she looked at when an article was received for review. And she said any person who writes a paper should address 3 questions or ask themselves 3 questions even before designing a project. Is it something new that you're doing? The data that you have collected, is it true? And most importantly, the research that you're doing, is it helpful information for our patients or community? So I think all of us should ask that even before writing a paper, but reflect on it again when you sit down to write your paper. So what is it? Is it new? So it could be a lot of things. It doesn't have to be an earth-shattering discovery to be published in Nature or Science, but it could be a new observation, a new technique, a new demographic feature, ancillary testing, a different clinical outcomes, or something that has not been reported in a particular population, but is something different that might have been reported before. So when you're writing your paper, I think you need to sell this point in the abstract, introduction, and discussion. So what is new about your study, and so that that's important to highlight. Is it true, and we'll discuss more about this when we talk about results, what you are presenting on what data you've collected, is it accurate? Is the analysis appropriate, interpretation accurate? And is the discussion to the point, and does it truly interpret the results? And the last question, I think the answer is self-evident here, where you want to see if you're publishing something useful that I or my colleagues or you and your colleagues can use as information when you treat your patients in your particular clinic or study. So now we start writing. We've collected data. We've analyzed the data. We've interpreted the results. Now what, right? That's what your paper is about. So, you know, the classic paper consists of a title, abstract, introduction, material and methods, results, discussion, some references, a lot of tables and graphs and figures. And the reason I highlighted the title and abstract in red is this is something you probably should address at the end. And why the title at the end? We'll talk about it. You can't get material in the abstract till you have finished your paper, right? You don't start writing the abstract right away. When you submit your IRB, you do it the other way around, right? Even there, once you finish all your planning, then you write the abstract, right? The abstract comes later. So that's the principle to remember. Now, if you had a good, detailed, well-thought-out proposal, your introduction should already be done. Your material methods should already be done. They probably should have tables already done, where dummy tables, I don't think we talked about it in detail, but what you would anticipate, where you fill in the results so that the biostatistician can analyze them for you. You should have those ready prior to starting your collection of results. So those are the things you could complete or should be complete theoretically before you start writing your paper. So where do you really start? You could start with introduction. You already probably have it in your background and significance when you review the literature and make the case that your study is important in your IRB application. But the point here is you can't write a mini review, right? You want to, journals have their constraints, reviewers have their patience that you don't want to test that. You really need to be to the point. 3 to 4 paragraphs, you introduce the subject, state the uncertainty in the literature or the knowledge gap that's there, clearly state your review question and hypothesis, and then rationalize the description of the study in a few lines. So having been an editor of a journal for many years, I've taken kind of examples from different papers over the years, and this is a good example of a good introduction. So here, the author is trying to tell you why the study is important and what is the problem that, the satisfaction is unknown, and then point out the knowledge gap. There's a gap in the knowledge. There is paucity in the studies to evaluate patient satisfaction. And then the research question, why is this study important? And that's all is needed. Often I find, being a glaucoma person, people will borrow this paragraph from Dr. Quigley's editorial from the Lancet and talk about glaucoma as a common disease and blah, blah, blah. That's not important. Whether it's any subject, you don't need to introduce it that way. You need to dive really into the subject and go from there, unless it's an unusual subject that you are studying. How about the methods? Now, in the methods section is for you to provide enough detail that the reader could replicate your study. Now, this comes with some caveats. So, for example, you're describing a procedure, right? And it could be something new. And you can't write 2 pages about the procedure. So either you would have to summarize it. Your procedure is probably not completely novel. It probably refers to certain portions of the procedure have been used elsewhere, so you can provide a reference to that. I'll give you an example. Okay, so you're doing a trabeculectomy, okay, for example, which nobody does anymore. But you're saying that the trabeculectomy is according to such article, but this is the part I modified, and I would describe that part in detail. Okay. So again, pay attention to mentioning your study design, sample size, technical information, and the actual statistical methods that you have used. So you don't stating that SPSS program 17 version XX is not enough. Okay, you need to say what was used and why it was used. And again, a common error is that we write it in, because it was written in the present tense in your material and methods for the IRB, that this is what you will do. Now you've done it, okay? So it is past, you've done it already. So some of the common errors and methods is insufficient detail, absence, inclusion and exclusion criteria, and putting the results in the method section. You don't want to do that. Methods is only describing what you did. You're so eager to show off what you've done, and you can put the results there. That's not being there. I think not common here, but in many institutions, people from other places, that they forget to mention that this project was either IRB exempt or approved, and that's important. And also, if it's a complicated study, making sure you address the assumptions that were made during statistical analysis. Coming to results, I think we said you want to make sure it's true. And I think if you have something new to report, typically when you do analysis, you want to analyze what you intended to analyze when you first proposed the proposal, right? But there might be something new that crops up, during your analysis, and you can do additional analysis or post-hoc analysis, and I think the best is to consult your best friend, your biostatistician, to make sure that what you're doing is the right thing you're doing. And you want to get your tables and graphs ready, and I'm talking a little bit more about that. And then you write your results section. One thing I like to do is, as I'm finishing the results, as you will see in the bottom area, in the section of discussion, you really want to discuss your results and nothing else. So you can highlight points that this is discussion point 1, discussion point 2, discussion point 3, and use that material to build up your discussion. So it helps a lot and to organize your thought process. And as you're in the results section, you want to make sure it matches your method section. For example, you said you collected visual acuity down to 14 or 15 tests, including ultrasound and axial length and whatever. And out of those 15 things you collected, only 4 are in the results. That's a problem. Either you didn't collect it, or you collected it and it was of no use, or you collected it and if it wasn't used, you don't mention it there in the method section. But what you have in the methods should be reflected in the results. You should have the results of what you said you were going to do. And you want to make sure those match. So again, we provide the data relevant to research. Again, you want to make it clear and simple. The statistical results should be relevant. And when you state, percentages can be misleading, right? So 1 out of 2 is 50%, right? I can say 50% of my surgeries were successful, right? And I have only 2 cases, right? So I think numbers, and both the absolute numbers and percentages, are of more relevance than just giving percentages when you write results. And you want to avoid too many decimals matter, okay? So even though the statistical results showed 12.222 millimeters of mercury, probably up to 2 decimals is okay. And statistical results, I think the more accurate way is not less than and more than. Probably the actual p-value is probably a better way to present it. Most journals prefer that these days. Now, when you have large data sets, like 100 patients or 200 patients, you probably want to do appropriate graphs and tables, okay? For example, I have 50 patients and I have clinical characteristics of all of them. I don't want to put that in a table, right? I mean, it's going to occupy 4 pages and probably not relevant. You probably want to concise that into either a pie chart or a bar graph. And I think again, the biostatisticians can be, or your mentor can be of great help on how to present the data in the right graph or table form. So aggregate data, for example, the demographic characteristics of a control and a case study group, that can be easily put in a table, right? 5 or 6 values, and that's a value, but large amounts of data. So for tables and graphs, make sure you provide abbreviations at the bottom. And of course, don't repeat the same data in the tables in the text. You do want to mention it, but it should highlight the important points. For example, I had, again, using glaucoma as an example, I have all the demographics on there on the table. So I say, well, in brief, the age was 20.5 years, and but of note is that there were more, women and male were this amount, right? If there's a difference, something that you want to highlight for someone to read so that they can go back to the table. If everything is the same, say, well, all the demographic features in both groups were the same, and end it at that. And then provide analysis by variable. So again, coming back to our results, if you have done it, if you have collected the data, there needs to be some analysis for that, right? You just don't, you can't ignore that. And that often comes in the types of analysis you do. I mean, there's often a descriptive component to the analysis where you just the percentages and the ratios, and then you have more sort of analysis where you look at associations, and those are also important as well. So some of the common errors I've seen over time is interpreting the results in the sections, repeating the data provided in tables, and the statistical results are, not used to derive the right way of p-value. And most of your studies that as a resident and fellow you're doing, and I think Dr. Ahmed Musa can reflect on that, they're often not normalized. They don't follow a normal distribution. And so the statistical tests often are what are called non-parametric tests. So a student t-test is probably not an appropriate test in that regard. So I think the right statistical stats, so like I said, we have the privilege of having a very good statistical team to make sure that this is important. Now coming to the last part, the discussion. Okay, this is the most difficult part often to write. And so you have to think like a lawyer here. You have to think and how to construct your case and make your case that what you have done or what was done, it really is of relevance, okay, and that's an important thing. So the elements to include in your study are to summarize the major features of the study, explain the findings and why they're important to sell it the right way. Again, compare your findings to other studies and also differences. And if there's nothing, offer alternate explanations to your findings without being too speculative. Acknowledge limitations and maybe make suggestions for future research if appropriate, and a concluding statement. How do you get that? Again, you need to relate your results carefully. Make a checklist of finding and interpretation. Like I said, I use comment boxes to do that. And then you probably have to do a literature search again to make sure. And you want to discuss there are 2 ways of doing it. One, you can go according to your results and discuss those. And I like to highlight the most important thing first. Bring that out first and discuss that. If an outcome variable was standing out and this was your hypothesis, I would discuss that first and then other elements later. So here's an example, okay, of someone who did a study on blindness in this province in Nigeria. I don't know, I'm forgetting where Sokoto is, but it highlights the prevalence of. So this is the first statement in the discussion. kind of summarizes the findings that this cohort of patients, there were no gender differences, and these findings were consistent with previous reports in the region, but also different from a different population based in Iran. So the importance of the study is pointed out right away. And in contrast to another one where I'm not going to say too much, but here is somebody who's talking about some studies described in 1756, spelling errors, and you don't need to do a mini review in your discussion as in the introduction. You need to get to the point and without doing a major review. Here's another one. Again, you can see why this is probably not the best way to start your paper. And these are real life examples. Okay, I'm sorry to say, but this is what. You don't, if you're going to reference somebody, you need to provide a real reference, not unless personal communications probably are not the best way to refer to an outcome, and that needs to be there. So as I said, you need to explain your findings and relate it to similar studies. And for that, you need to review the literature again. So often, by the time you finish your study, maybe it's a year, right, year and a half, something new probably has popped up in the literature, often, right? You don't want to miss that. So you need to go back, look at the literature, make sure you're updated in the literature, and then you reflect on the findings. Is it the same of what you expected that you'd find in your hypothesis, or is it different? Explain it, and then point out what is unique, and you may have no clue, but you have to think and explain it, or just say, we need more studies to explain. So there needs to be some conclusion to something, the new thing that you have found. So here's an example, which is probably reasonable. Again, it highlights the patient population and states that there is a gender difference. And the conclusion was that it stresses it's in West Africa is different from other regions and stresses the need for need for the early screening of DR in this very population that develops DR in a young population. Now here is something which probably is I really don't like to see in a paper. They've pretty much done a mini review of GCC thickness in glaucoma. That's not needed. The relevance is lost in this detail. So you need to be to the point. And then you need to offer alternate explanations if you don't have any based on the studies. And you need to honestly discuss the differences. I know you want to highlight your study. You've spent so much time. You think you are doing something great, and which you are. But I think you need to be honest on analyzing. That's critical thinking, and often mentors and colleagues can help you with that. And then offer alternate explanation. And your point, your purpose is to discover and not to prove yourself, right? That's important to think about that. So it's easy to fall into that trap, to prove your bias, than to discover the truth. Very easy to do that. So you want to critically think and make sure, because people might read your paper and do what you're saying, right? And hopefully you want it to do good rather than harm, right? So that's very important. So here's something about the role of voriconazole in fungal keratitis, telling you that is different from the literature. And then they hypothesized that the differences could be due to unique demographic differences in the group that they studied versus those reported. And this needs to be supported by the findings. So there should be a correlation. And something like this is kind of more being vain and not very helpful, right? They did a study which completely treats all astigmatism and scarred corneas, and they thought that others have a limited success, but they don't understand why they didn't get better results than they did, right? Not very appropriate to say something like that, right? Another one similar, a new technique was described, and they talk about molecular changes in keratocytes without any evidence. And there's totally speculative, right, without any evidence. And you don't want to get into that problem. And you need to acknowledge your limitations. Often no study is perfect. I think if you do that, then it'll make, study not come back from the reviewer. They know that you have thought through it and it's helpful. So I think one of the things is, an example of a few limitations is that you've looked at the sample size, but also, put the positive side that the highly significant differences between these cytokine levels and controls suggest that these differences are real. And again, reflect on the study saying that probably a larger cohort with a longer follow-up period is needed to validate. That means you've thought about the study, you've thought about how this implies. The don'ts in the discussion, don't cut and paste stuff from your introduction, right? Don't do that, don't repeat it. Don't make it a literature review, which already talked about. And don't introduce new results in the discussion. And I've seen this often. There's so many people reviewing the paper, and one mentor says, okay, you got to include this, and in the discussion, you forget to mention the results. So don't do that. And don't indulge in unwarranted speculation, inflating the importance of findings, repeating the results, over-interpreting, and focusing on tangential results. Using biased language or biased citation. So this is can be a problem, especially if your paper goes to important reviewer. There are some very well-known authors who are known to self-cite only their papers. And they have 1,000 publications, right? There are other people who do the same work. And not giving others credit or being fair probably should be avoided. And then the important thing about clinical importance and statistical importance, right? So you have, and I always use this intraocular pressure issue, right? So if you have a large enough cohort, as the statisticians will tell you, you can get a positive p-value if it's huge and the difference is small. So you can have 1,000 patients, the IOP is 18.5 and 17.9. That's the difference of 0.6, right? What's the error of a Goldman? Plus minus 2, right? It's highly significant. Is this clinically relevant, right? Probably not, right? You don't know, but it's statistically significant. So you have to be careful in your clinical judgment on how you do that. And again, the do's, I won't talk too much about that. You're using the correct tense, using the active voice. I think these often are helpful for the person who's editing or helping you with language editing, can be helpful for this. One difficulty I think novice writers have is writing it and kind of making the paper smooth. Linking paragraphs, the first paragraph to the second, so the thought process goes in a smooth way. So for example, and this can be difficult, and I think the only way to do it is by repeatedly reading your manuscript, have your best friend take him or her out for a coffee and have them review that for you, and you can do likewise for them. So for example, you have paragraph A, where you talk about this IOL size, supports the view that a 6.5 millimeter IOL during cataract surgery and pseudoexfoliation is useful. And then you want to make an argument that despite the previous arguments, there are many reasons to think that 6.5 is not useful in this situation. And then in paragraph B, or in the same transition, you can cite the literature as to why you think this is not useful, right? So there needs to be linkage so that your discussion is smooth. And then you want a concluding statement at the end, which is useful, which is the take-home message. Often a part of it is the conclusion in your abstract. And you can see how one could reflect on this paragraph and take things out in the paragraph to make it more orderly and well-written. So there are tools out there to help out you. So a nice tool is Grammarly. I don't know how many of you know that. It's a AI-based, web-based tool. It's subscription-based, but very useful in making things more concise and writing in a proper way. So that's something to think about. And maybe we in research should think about how we can subscribe for that to help our novice researchers, to help them. And again, in the concluding statement, avoid inappropriate conclusions beyond the range of data. For example, here, there's a study in Iran on fungal keratitis, but you cannot talk about this being relevant to the entire Middle East and Africa region where the disease might be different totally. So you can't interpret or over-interpret the findings, and this is probably was only relevant in that particular region. So you got to be careful. So to summarize everything in the discussion, list all the relevant points, do a new read related papers again, because by the time you've finished everything, you probably forgot what you wrote in the beginning. Do a new PubMed search, write discussion in paragraphs, go back and read, link the paragraphs. Important to put the paper aside for a few days and then come back. And I think it's very helpful. And then link the conclude. Then you come back to the title. You're coming back to the title. So some things might have changed from what you started off, right, with a little bit. So I think this is the time where you want to make sure your title is appropriate. It should be concise but descriptive, not too long. But, titles with questions are not a good way to present a title. Like, has extracapsular surgery reduced blindness in the rural communities of Uganda? Not a good way to do that. It leaves an open-ended question, and that doesn't really describe your study. Your title is to describe your study in a concise manner, right? So probably the second statement is a more appropriate one if that's what you've done during your study. And then you come to the abstract, because now you have the whole package, and you can take bits and pieces of it and do that. So again, most abstracts are restricted to 200, 250 words. Again, dive right into the problem, addressing why you did the study, the techniques in a few sentences, the most important results, and the concluding statement, and of course, don't cite references in the abstract. Common errors in an abstract I've seen over time. Journal instructions are not followed. Most important results are not highlighted. The abstract results are not same as those in the manuscript, and those often the error comes if you write the abstract first and don't go back and look at it. So that is often there. And then the conclusion doesn't match the results or it's too strong, right? So you have to be careful with that. So in summary, remember the golden rules. I think Dr. Khalid will tell you more about what the reviewer's mind looks at. Do not plagiarize, okay? There are editing software to look for that, and most journals will run it by that. That's almost an instant reject for you. So don't do that. And do the writing in a little lopsided manner, starting with your methods and then going backwards and then finish. Don't forget to share and get feedback from co-authors, right? You signed a paper saying that Dr. A, B, C, D are going to do X, Y, Z, right? So that's what you said in the IRB. And so don't submit a paper without your co-authors reviewing the paper. It's a common error. And that's not appropriate, okay? Well, happy writing.
Thank you, Dr. Deepak. Well, I certainly learned a lot from that very useful lecture. And following on from that, we have Dr. Khalid, who has published more than 300 articles. He has served as a reviewer and an editor. So we'll get to pick his brains on his insights into how to having your paper accepted.
Thank you very much, Dr. Radwan. Actually, Dr. Deepak covered most of the things, so I'll try to concentrate on different angle in writing manuscripts and so on. The first thing is actually choosing the right journal. So clearly we are in the field of ophthalmology, so it will be appropriate to actually make a list of all ophthalmology journals. Review the articles for the last 3 to 6 months, okay, to see whether your manuscript actually fit within the scope of what the journal is currently publishing. Science, sometimes it's like fashion. So in certain times, you find that journals, they pick up like certain topics. Like I remember when gene therapy first came out, years ago, you find that lots of journals are actually covering things in gene therapy. So look at what the trend is and look at various journals. So if you are publishing, let's say, a case report, look at the case reports in that journal, see whether your case report fit within the scope of the journal or the trend and so on. So picking up the right journal is very important. Start with ophthalmology, ophthalmic journals. Then if you are publishing case reports, maybe you pick up journals which give more emphasis on case reports. Don't set the bar too high. Look at the novelty in your article, whether it's a different angle, it's a complete novelty, you have a new clinical findings and so on. So you will be able to tell whether that particular journal might actually accept your article or not. In the old days, we used to write to the editor-in-chief, and we like identify 6 to 7 journals, and then we write a standard email saying that we have this article, this is the abstract of the article, would it be suitable for your journal? Nowadays, editor-in-chief don't answer back quickly like before, you know. So this is basically left to you. This is your homework. So you go to the table of contents and you look at the articles published in the last 6 months or the last year. And if you see that your article somehow match the trend, then you go for that journal. Make sure that the audience for the journal, who reads that journal. This is very important. You don't go for an article which is purely clinical and you publish it in a like a basic science ophthalmic journal, you know. So you have to be really careful about that. Journal reputation and impact, if this is important for most of us. When we used to work at the university, for example, they used to put certain standards where the journal have to be indexed in the ISI. Whereas maybe at KCASH, this is not a crucial thing, but the journal have to be indexed somewhere, in PubMed, Scopus, Google Scholars, and so on. Look for journals which is well regarded in your own discipline, okay? And if time to publication is very important for you, look basically at the table of contents, see when the articles were submitted, when it was reviewed, and when it was accepted for publication, and when it was actually published. This is very important. Sometimes people need publication for promotion and so on. So this is a very important point to take care of. For the review process, you look for journal with a transparent and efficient peer review process. And some journals, they allow you to provide names for like 5 or 6 potential reviewers, okay? Not necessarily that they will send it to them, but they actually build a database out of the information you give them. And now most journals are actually open access, okay? And open access meaning that there are charges you pay for the article. And the old days, it used to be quite reasonable. Nowadays, like average article is about like $3,000 per article for an open access. And the open access, basically, for those of you who not familiar with open access, before journals used to belong to societies. And usually journals used to get their money by the subscription of the members. But then the trend was that, and these journals where you cannot access it easily, you have to pay to access the article. Then there was initiatives to make articles and science more open access. But in that case, there was a problem who's going to actually pay for the journals to maintain their expenses and so on. So now they pass it on to the actual person who's submitting the article. So this is something you have to be aware of. Look at the cost, how much it costs to publish in that journal, and how you are going to actually cover the cost. My understanding that here, usually KCASH will cover the cost if it's an approved project and the manuscript has been approved to be submitted to the journal. I think you pay first and then they reimburse you for the processing charges. Ethical standards, publishing ethics, avoid journals. I fell on a trap for one of the journals where it was like totally fake journal. And these things do happen sometimes. So go for journals which are indexed for at least the last 5 to 10 years. So you go to PubMed and you look to see that the abstract has been indexed. So you make sure that the journal is actually indexed and it's been there for some time. The title, I'm not going to speak too much about this because this is covered by Dr. Deepak. There are so many AI tools, and honestly, some of them, they are really good. They check the grammar, they check even the flow of the manuscript, how the manuscript flow, does it read well, and so on. Always, when you write a manuscript, imagine that you are writing a story. Because if you program yourself that you are writing a story, the flow of the manuscript will be much better. Okay, because the story have to make sense to the person who reads it or who listens to it. Okay, for the title have to be clear and concise. Okay, and usually, personally, I don't write the title at the beginning. Okay, I look at the findings, and after that, after I write the result section, which is usually the first part which I write of the manuscript, then I choose the title based on the results, okay, and the findings. Avoid ambiguity, keep the title short, okay, make it eye-catching because that's the first thing the editor will look at, the reviewer and the editor. And try to make a title which comprehend everything you are doing. Sometimes it's difficult, but try to make it concise and cover what you actually investigated in that article. Use keywords in the title which people can actually easily find if they do a certain search. Avoid complex language, match tone of the journal, and avoid titles which they are too broad and they don't reflect what you actually did in the manuscript. The abstract also, some editor-in-chiefs, maybe they don't have so much time, or they have people who screen manuscript before acceptance, before actually sending it to reviewers. Okay, so make sure you invest time in writing a strong abstract, eye-catching abstract. The abstract should cover most of the section of the paper. Some journals, they have structured abstract where you have the background, the methods, results, and conclusions. So make sure you confine to the journal instruction for authors in terms of the abstract. Here it says highlight the research problem. You can highlight it first, then you write the methods, and finally the conclusion. Conclusion, as Dr. Deepak mentioned, should also reflect on the actual work you did. You don't overstate the conclusion. This is very important, so you should reflect what you actually did. Remember always, first impression matter, because as I said, there are certain journals where people actually screen manuscripts by looking at the abstract. Then they decide whether it's actually fit the scope, then they send it to reviewers. So take your time to write a good abstract. The introduction usually try to cover most of the background. It will be, consider the major thing that if you missed one of the articles and so on. Sometimes when I write introduction, I concentrate on recent reviews, okay? So if you are doing something in, like, say, primary congenital glaucoma, what's better than going to a recent review in primary congenital glaucoma, because highly likely the guy covered most of the literature, But then let's say that the review was published in 2023. Maybe after that you pick up articles published from 2023 until 2025 and so on. That's one way of doing it. Okay, setting the stage for your research, state what are you doing, after you mention the background, you mention briefly the research problems, and then you clearly state why you are doing this research and what you've done, what you are going to do in this paper. Provide a concise literature review, we spoke about that. Divide the scope and limitation of the study, okay? So what you are going to cover, and the article will be limited to certain ethnicities and so on. You define the research objectives and hypotheses, but you don't go in details here in the introduction, because there will be a research objectives section. Okay. Methodology should be clear. Demonstrate most of the methods you used in the paper. It should be mentioned there. Some people in technical papers, they demand a detailed methods in order for people to repeat the experimental work if they decide to do so. And clearly in the methodology, if there is statistical involvement, you should mention that. The result section should be presented effectively. Try to use tables and graphs and figures to enhance the clarity, but don't repeat the results in the figure. You repeat it in details in the result section. You can write briefly in the result section, and the rest is actually presented in the tables and the graph. Ensure the data is accurate and well organized. Avoid the overinterpretation, okay, especially when you go to the discussion section. And we talk about that, don't overestimate the conclusion. Make sure that the conclusion actually match with your findings. Statistical analysis, if applicable, should be also mentioned. And you focus on the key findings, okay? So if you find certain things which are not the major focus or the major focus of the research problems, then maybe, you mention it, but you don't actually highlight it. I find it useful also if you done, like, for example, let's say you investigated 4 different SNPs, divide the results into 4 different sections. Because when you come to write the discussion, you can actually discuss things as they are ordered in the results. So the person who's reading the results, he's following easily, and he read the discussion and he's following things in relation to the results section. Okay, discussion, interpreting the findings, and of course you connecting the dots. Here you don't have to, one of the major problems people do in discussions that they repeat the results section. But that's not what you are supposed to do in the discussion. Here you need to collect things, intercalate various things together, and discuss the implications and the limitation and how these things are connected and how they might contribute to resolve the research problems. Here in the discussion also you can compare with previous research, and the discussion should have a logical flow. So let's say you are talking about 4 different SNPs in the result, and then you do the same for the discussion. Make sure that somehow it matches and it follow a logical flow. And highlight unexpected findings if you want also. Okay, this is strategies for aligning manuscript with journal scope from research to resubmission. Make sure that, as Dr. Deepak mentioned, you can ask a friend to read your manuscript and see how much he understood out of that, to make sure that the flow of the manuscript follow a logical thing. Here it says match your research to the journal focus. We mentioned that initially on picking up the journal. Tailor your title and abstract as per the journal scope. And of course, follow the journal guidelines. Why manuscript get rejected? There are many reasons. Poor alignment with the journal scope, okay, clearly. Lack of originality and significance. You are cogitating science. You are not providing any new or novel findings. Problem with methodology. Poor writing and organization, okay. The manuscript it's not organized, it doesn't reads well, and so on. Inadequate literature review. As I said, you have to cover most of the literature review. The worst case scenario that you missed a major article and one of the reviewer picked it up. In that case, but usually that's not a reason for rejection, because they can highlight you into, to go back to that article, unless your work you missed that article, and that article, did almost the same work as you are. In that case, your manuscript will get rejected for lack of novelty. You have unethical concerns. Patient were not, informed consent was not obtained from patients, and other ethical problems. And conclusion don't match actually the results you obtained. You overstate the conclusion. And so this is one of the major things also for rejection. Thank you very much. Thank you.
Thank you, Dr. Khalid. So statistical analysis is a whole topic in itself, which you could dedicate a week to. But Dr. Musa is going to give us a summary of the statistical considerations you should apply to your project in the space of about 20 minutes. Thank you.
Since this is the last lecture, so I tried just to put it into very quick hints to be utilized while you are conducting your studies. We will take a quick picture about what types of data we use. We need to know that the ophthalmologic data, usually either they are numerical data like the visual acuity, the IOP, the cup disc ratio, and so, or it can be also categorical, such as right eye, left eye, male, female, and so. We need to distinguish this from nominal data, which is something that is not categorical, such as the different subtypes of glaucoma, for example. Again, there is another type, which is the ordinal, like when we say mild, moderate, severe. This is another type. Nowadays, we are utilizing images so much. So why it is important to know that nominal is different from ordinal, is different from categorical, is different from continuous variables? Because based on that, we are going to select our statistical analysis. So one of the quick questions always being asked, how do I design my data collection sheet? So again, the treasure is the literature. Go for the literature review and see how people worked in similar studies organize their data collection sheets. From the literature, select studies that are very close to your topic and look at the variables that have been collected by your peers, and then you can use also your expertise. If you want to add a variable, remove a variable. If you are going to add some potential risk factors, if you are going to add some findings from the lab, if you need to calculate a complicated index like success rate, like body mass index, something like this. And keep always in mind your main outcome measure that you are going to judge your study with. By this, you can put bits and pieces together and develop your data collection sheet based on your study. So once you finalized your final set of variables that you are going to collect, make sure that you put in your database a unique identifier. This is something that people miss a lot. Like you don't put, for example, serial. We use first variable, we say the serial number, okay, the sequence number. This seems to be something that's ignorant, but it's very important while you are doing the analysis to know which case is this, if you want to retrieve it, if you want to get back, if you want to link it to any other variables. Sometimes we need to link two data sheets together, so unless we have a unique identifier, it creates a lot of problems. In your descriptive section, before you go for the clinical issues, make sure that you have the set of demographic or socio-demographic or socio-geographic data that you want to include in your data collection. For example, some of the diseases are more prevalent in the south, in Jizan, Najran, so some are more prevalent in RR and the northern borders and so on. Select your systemic indices. For example, our friends and colleagues usually have a set. They say hypertension, diabetes, bronchial asthma, chronic heart diseases. Don't go for a ready-made set because it's not a routine thing. You are doing research. See which one of those is highly related to your study and then start to include it as a set of systemic indices. Then take into consideration that you are going to analyze and link data. You are going to assess differences, effect sizes, correlations. So put your potential analysis on the inferential part also in your consideration. One very important issue is never sacrifice a continuous variable. If you have a continuous variable like age, height, weight, that something can be decimal, never sacrifice this continuous variable because it leads up to very good association unless you have something that is very specific, like you want to split your variable into people before 50 years, people 50 years and above who are more susceptible to, for example, senile cataract. Unless you have this, try to make sure that you keep very well your continuous variable. Now, if you are comparing multiple arms, account for the matching. As we mentioned that all characteristics are the same except for the intervention, except for the disease of interest, and so on. Now, if you go for timetable or survival analysis, make sure that you have the date of failure. Some people would bring this research, their data collection sheet, their databases to the research department and say, please help me analyzing this data. I want to calculate the average survival time for patients after glaucoma surgery. And then they don't have the exact date of failure. Unless you have exact date of failure, the epidemiologist or biostatistician will not be able to help you to calculate the exact survivorship. So risk factors, potential risk factors, effect sizes, all this you should put into your consideration while you are doing your data collection. Now, if you come to a scale or a score analysis, you have to make sure that you have the methodology for analyzing this score, because each score or index have been developed by a group of scientists. For example, they develop the way of analysis, because they would tell you how do you calculate the scores, how do you add them up, how do you correlate them to other variables, and so on. So be careful when you go for indices or scales or for example, Likert scale analysis on all these things. If I am comparing pre to post intervention comparison, so the whole thing is about either one of two things. Either you have two groups, you have group A, you have group B, and you are comparing the two groups. This is one type. Or you are comparing pre to post. This is one group, you are comparing pre-intervention to post-intervention. So it's either this or that. But in this case, try to standardize the measurement. If you are using Tonopin, use Tonopin. If you are using applanation, use applanation, and so on. If you have several follow-up assessments, this is one of the very common mistakes my friends, people would do. They say that I assist post-operative visits, visit 1, visit 2, visit 3, visit 4, visit 5. Never use visit as a time. Use months, because if you use visit 3 can be after 3 months. Visit 3 of the same patient can be after another patient, can be after 6 months. So to be sure and be clear, use months. Don't say ever the patient came in the first visit, in the second visit, because this is gonna confuse everything. Again, you have data on medication. Avoid permutations and combinations. What does this mean? If you have a variable that is called medication, okay, and you are using a specific antibiotic A, antibiotic B, antibiotic C, try to make sure that you are not saying antibiotic A plus C plus 3, antibiotic 4 plus 5 plus 6. This will create a whole set of combinations, and permutation will be very complicated to be analyzed later on. So this is Kaplan-Meier test. It shows us the survival rate, at which time these steps you see are the dropouts while following up patients for a long period. So while doing something like this, like timetable analysis, we need to make sure that the number of subjects is enough at the beginning, at baseline. We need to make sure how many dropouts happen, because if it is 1 or 2 or 3, it doesn't mean anything. It doesn't give you any reading. We need to make sure that we have the exact date of failure before doing this, and we have the option that we can compare 1 or 2 or more survivorship if you have several groups. So are you trying to calculate the effect size? Then you go for regression analysis. Make sure that your data or your dependent variable or the variable you want to assess the impact of other variables on is a continuous variable if you are going for a regression analysis. However, if it is a binary variable, means success versus fail, then you make sure that it is a dichotomous variable. What in case that I have a variable that has 3 categories? I have a variable that has 3 categories, such as complete success rate, qualified success rate, and failure. In this case, I add up the complete to the qualified to make it one variable, and I call it success. I should end up by having 0 and 1 if I want to use the logistic regression analysis. Some people may go more further sophisticated and utilize what is so-called stepwise. To use this stepwise, the computer will do reiteration to include and exclude variables till it ends up by setting you a final set of variables. So to do this, it's highly recommended that you start by binary analysis and then go for the stepwise. Now, if you are using Likert scale, make sure that your questionnaire, as Prof. Edward said at the beginning, this questionnaire should be validated, tested for reliability and validity. If it is used internationally, you can then do localization. If it is your innovation, it has to be having a committee to judge it, and you have to test it with a pilot study. And make sure of the coding system and that will be later on used in the analysis. This is a very good example of Likert scales. Likert scales can be 3, agree, neutral, disagree, can be 4, strongly disagree, disagree, agree, strongly agree, can be 5, it can be 7, but it cannot be more than 7 in very, very rare cases because it loses its evidence. So make sure when you talk to people using a questionnaire, which language, which accent. A questionnaire that has been developed in Egypt has the Egyptian accent. If you want to apply it here, you want to use the Saudi accent, for example, and so on. Try to code your data collection sheet by yourself, because once you code it by yourself, you are sure that if it is not coded by someone else who can change the arrangement of your variables. For example, utilize a categorical variable as an ordinal variable and so on. So it's better while you are doing your data collection sheet, try to say by yourself, male is 1, female is 2. And why this is very important? Because if I'm going to do a logistic regression, for example, and I'm using success versus failure, and I want to assess risk factors for failure, then I will put failure as 1 and I put success as 0. This is a very important point that people don't realize actually. Now, try to be very comprehensive. Get your demographic variables followed by your systemic variables followed by your ocular indices, and pre-intervention variables and post-intervention variables should be always the same, and organize them in a very nice way, as we can see. It's very important to consult your team before you go for finalizing the data collection sheet. Very important. If you have in your team a scrub nurse, for example, if you have optometrist, for example, if you have a technician, for example, try to consult your team before finalizing the data collection sheet, because they may have some notes for you that will facilitate your mission. Finally, when you come for reporting your findings, try to avoid inconsistency. Don't write a very big introduction and very small result section and more or less 2 paragraphs discussion. In the results section specifically, because it's my area of interest, try to avoid what we call the statistical kitchen. If the statistician applied 10 tests for you, select from them. Don't say anything that has been mentioned in your report and transfer it into results section as is. Select from tables, highlight findings, and then you can always plot nice plots to attract the vision of the reviewer or the reader, but please avoid a very important point. Don't plot the same data that you put in a table. If you put them in a table, that's it. If you didn't put them in a table, put them in a graph. If you feel like it very short, write them in 2 lines. And I think the rest of issues have been covered by Dr. Khalid, Dr. Edward, and Dr. Malik. And finally, I will repeat to you again that you are welcome at any point of time. If you feel like you have a question, if you feel like you have a question, you have a draft, you wrote 2 pages or something, and you don't have time, you can share it with us by email, and then we can also respond to you. So thank you very much. Thank you for the day, and thank you for our colleagues.
So does anyone have any questions for Dr. Ahmed on that talk or any previous talks at all? Okay, so hopefully you've seen some of the methodologies and also the research processes here at KKESH, that a research question can be translated into a project and into an eventual conclusion. In summary, the various study designs that can be used. You need careful planning from the outset. Okay, if you don't carefully plan your study at the beginning, it's going to be very difficult to get a good quality paper at the end. You need IRB proposal for an approval for all projects. We are here to support you for every stage of the project, whether it's in planning of the study, to fill in the forms, or to get statistical support. And if you're not sure about any of these things, please come and see us. Ideally, we want your study published at the end in a high-index journal. So can I just get an idea, which of you are residents? Okay, so residents, you know, R2s should have started their resident thesis. Okay, R3 should be well on the way to well into their projects, and R4 should be finishing their research thesis. F1s? Okay, so F1s should have identified their major project. Okay, if you haven't identified a major project by now, you've been into the post 2 months, you should have identified a mentor and a research title. If you haven't, please come and see us and we'll try and sort you out. F2s? No F2s here? F2s, they don't need to come because they've finished their projects, hopefully. Okay, good. So we're here to help, and if you need anything, then please email us or please drop in, come to see us. We're very amenable. And I really appreciate any feedback that you have for future courses of this course that you can give us to help improve it or make it more relevant to you. So if you have time, please fill in the feedback form, put in your comments there, or if you feel more comfortable, you can just email on this email and let us know. Okay, thank you very much.